a PI meeting for the SWOG S1914, and so we're looking forward to talking with each site. We have some exciting news about an amendment that Megan will be discussing with everyone. I'll kind of give a little bit of background about the study as it has been going for the last year and a half or so. And then we really want to hear from each of you about how the study is going at your institutions and anything that we can be doing to help and any challenges that you may be running into. So with that, this is an intergroup trial and a true, really great cooperative trial between SWOG and NRG. You can see a great team here. Megan, the overall PI, and SWOG PI, and myself as the NRG PI. But co-chairs from radiation oncology, medical oncology, translational physics, and quality of life and stats all split nicely between NRG and SWOG. All right, so to kind of understand a trial that's involving SBRT and immunotherapy for early stage lung cancer, I want to spend just a couple minutes talking about the potential benefits of combining radiation at all with immunotherapy, which is probably not new to the group, but probably a little bit more known in the metastatic setting as opposed to the early stage non-small cell setting. SBRT we know is less immunosuppressive than conventional radiation or than surgery, quite frankly. So we can actually see that SBRT can be immunostimulatory and deplete immunosuppressive cells that can allow for better synergy with immunotherapy. Radiation in general can improve antigen presentation by APCs, and SBRT specifically releases a high level of tumor antigens. So again, maybe great to synergize with immunotherapy. SBRT can upregulate immunogenic cell surface markers like MHC1. It can induce immunogenic cell death. And all radiation, but especially again SBRT, can increase homing of immune cells to tumor. Radiation can also recruit Tregs. It can shift tumor-associated macrophage polarization to more radiosensitive phases of the cycle. And it could also induce secretion of things like TNF-alpha. And then interestingly, radiation can upregulate cell surface expression of PD-L1 tumors and even turn cold tumors that don't have recorded PD-L1 levels to have PD-L1 expression. So all that is great rationale for using radiation, and especially SBRT in general, with non-small cell lung cancer immunotherapy. But why use it for early stage non-small cell, which is really the focus of this clinical trial? It's really, we know that surgical lobectomy is a standard of care in patients who are fit, early stage, and have resectable disease. Historically, these patients are getting adjuvant chemotherapy for high-risk features such as larger tumors, and certainly if they're found to be node positive. And that's improved overall survival. There's increasing use of adjuvant immunotherapy and even neoadjuvant immunotherapy now to further improve outcomes and reduce the toxicity profiles. But we know a sizable portion of our early stage patients are getting SBRT either because they refuse surgery, they're medically inoperable, or they have some other contraindication to surgery. For these patients, SBRT alone is great for local control, 95-ish% local control across the board, but we're still seeing up to about a quarter of our patients having regional or distant failures. And that's a significant number. But we really, to date, have not done much for these patients outside of SBRT, and unfortunately, surveillance and waiting for them to fail, because we typically have not thought that chemotherapy is great for them. They typically are older, frailer, and more comorbidities. But immunotherapy in this patient population can allow for fewer nodal and distant failures, and it can be better tolerated than chemotherapy would in this patient population, and can be given safely either before, during, or after SBRT for early stage non-small cell lung cancer. So that's really the trial we're looking at. The S1914 schema is here. Patients are randomized up front, and the stratification is central or peripheral, and then large tumor size or not greater than 4 centimeters, which is a cutoff used in surgery for deciding historically should patients get adjuvant therapy, as well as by performance status. And you'll notice that this is the first cooperative group trial that's allowed both central and peripheral tumor locations, and it's also allowing ECOG2 patients, as well as tumors over 5 centimeters. So it's much more pragmatic than prior studies have done. After randomization, patients randomized to the control arm receive SBRT, and SBRT is also pragmatic at 3 to 5 fractions, and then they go on to receive follow-up. In the experimental arm, SBRT is combined with immunotherapy using atezolizumab, in 3-week cycles for a total of 8 cycles. So it's a little less than 6 months total of hormonal immunotherapy. Here, the interesting thing about the study is we actually prime the immune system for 2 cycles of immunotherapy. So atezo is given on day 1 and 22, and then on cycle 3, day 1 is when the SBRT starts. So there's about a month and a half or so until the SBRT actually is delivered, and then continuing for those last few cycles of consolidation. Why that timing versus, for instance, giving the immunotherapy afterwards? Well, this is data from my institution, MSK, showing for melanoma, but similar agents, this one with ipilimumab, showing that patients that were started out on radiation and then given immunotherapy have a much inferior survival versus patients started on immunotherapy and then added in radiation therapy. That difference was 9 months versus 39 months. Now, of course, there could be confounding in the reasons for that, but that led Megan's institution at UC Davis to explore this specifically for the agents that we're talking about in a non-small cell lung cancer model. And you can see the middle lines, so this bright blue is radiation alone. And it does have nice tumor kill relative to the control that's in black. When you give radiation followed by immunotherapy, you get a little bit more cell kill. This is the red line here, but it really is a little bit additive. It's certainly not exponential. But interestingly, when you give immunotherapy first to prime the immune system followed by radiation, you can see a dramatic difference in cell kill. So a lot more superior tumor killing when immunotherapy is delivered first. So with that, this study was founded on the hypothesis that the addition of atezolizumab to standard SBRT for early stage medically inoperable non-small cell will improve overall survival as well as progression-free survival compared with radiation alone. So the primary objective is looking at overall survival. Secondary objectives is progression-free survival, local control rates, as well as distant and local regional control rates, frequency and severity of toxicity, and this trial, since it is a phase 3 trial, is also looking at quality of life. These are the inclusion and exclusion criteria as written for the first year plus that the trial has been open. Pretty standard. There's some common exclusions for immunotherapy, but otherwise the trial is pragmatic. The one difference is it is enriched to have a little bit of a higher risk of nodal or distant failure. So patients have to have at least one high-risk feature that are identified here in red. So the tumor can be greater than 2 centimeters in diameter, which is a common enrollment use. Tumors can be particularly bright, SUV max of greater than 6.2, which has been shown to have a higher prognostic for failure. And then patients can have moderately or poorly differentiated histology. As long as any one of these are fulfilled, patients are eligible if they meet the other criteria. Patients really just have to be an ECOG 0 or 2 and be medically or surgically inoperable or unwilling to undergo surgery. Tumors up to 7 centimeters are allowed. Radiation regimens, again, are pretty flexible. Any regimen that's been used on a prior cooperative group trial, we've included. So 3, 4, or 5 fraction regimens have been used as long as the BED is greater than 100. And atezolizumab is a 60-minute infusion every 21 days for 8 cycles. The statistical design, again, primary objective is overall survival. We need 480 evaluable patients to be able to answer the question, assuming a 10% ineligibility. We're expecting a 43% improvement in overall survival with the addition of atezolizumab to SBRT. So a pretty significant change, and we have an 80% power to detect a hazard ratio of 0.7 with a one-sided p. Secondary objective is PFS, and there we have a 90% power and an even higher improvement in PFS projected. We do have 4 interim analyses. All of them look at futility, and then the last 2 also look at efficacy as well. And we're expecting to continue at a rate of about 8 patients per month. You'll see where we are relative to that, but we're actually hoping when we designed the trial, we thought that was a conservative number, and we're hoping that all of you can help to make that a conservative number. And the trial is expected to continue for a total of about 5 years. And we do have some neat laboratory correlates planned that'll be performed after the primary trial is completed, but everything from thinking through circulating tumor products, et cetera.
All right, so Thanks, Chuck, for covering all of the background on the trial. I'm now going to touch on our two most recent set of amendments. We first had an amendment in May of 2021, and although we did review this briefly on the last investigator meeting, I wanted to highlight some of these before jumping into our recent amendment from last month. So in May of 2021, we provided additional language clarifying normal tissue volume and constraints. We'd gotten some questions around those. For example, we clarified that the chest wall and ribs are guidelines rather than hard constraints, and patients do not need to be removed from protocol or counted as a major deviation if those cannot be achieved. We also relaxed the eligibility criteria around prior or concurrent malignancies. We're trying to be as pragmatic as possible. And we know in this patient population, many of these patients will have had prior malignancies or other concurrent low-grade malignancies that don't affect their lifespan. So we're now only excluding prior or concurrent malignancies if the treating investigator believes the malignancy or treatment has the potential to interfere with the safety or efficacy assessment of the investigational regimen. So this is a major change. And, so far we've seen that this has allowed some patients to enroll who otherwise would have been ineligible. We added an optional quality of life questionnaire. And we clarified the response for assessment criteria after SBRT to better align with prior cooperative group SBRT trials and to provide clarity on how to assess the patients who are suspected of recurrence. As we all know, assessing CT changes after SBRT is a complicated issue in radiology, and we're hoping that this additional clarifications, provide appropriate guidance. That you can certainly reach out to us if there's any questions about, how to document a patient or how to move forward. We go to the next slide. So that brings us to our July of 2022 amendment. So this has just gone live, and we're very hopeful that this will additionally help with accrual. And several of these were directly into response from feedback that we got from investigators at various sites. So we first clarified that the tumor diameter eligibility does include non-solid ground glass components. So if you have a patient with a 2.5 centimeter abnormality in the lung with a 1.1 or 1.5 centimeter solid component, that patient would be eligible. That ground glass component does count toward the 2 centimeter cutoff. A major change was allowing patients with 2 synchronous early stage primaries to be included, or with a multifocal tumor with up to 2 sites of disease. Previously, we were only allowing unifocal tumors, but we found this was excluding a large number of patients who otherwise were excellent candidates for the trial, and we got quite a bit of feedback that this would be helpful to allow these patients to enroll. We do require that at least one of the tumors be biopsy confirmed, and we continue to require biopsy overall for all patients on the trial. Importantly, we are also allowing now the 7.5 by 8, so 60 gray and 8 fractions as a regiment. And I'm sorry, that should say 8 fractions, not 8 gray there. For central tumors, we were definitely getting feedback that for some patients with ultracentral tumors, some of our treating investigators weren't comfortable with 5 fraction regimens. There's certainly challenging tumors where the 8 fraction regimen may be a better option. So this is now allowed on the schema as one of the allowable SBRT regimens. We are no longer mandating minimum PFT values. That was not entirely evidence-based. There's really nothing in the literature to suggest that there is a minimum PFT cutoff below which SBRT cannot be safely delivered. So that has been removed, and it's now really at treating investigator discretion as to whether the patient is an appropriate candidate for SBRT. And then finally, we have gotten a number of questions about our assessment time points. And so we've tried to really clarify throughout the protocol that these are based on the date of randomization. And so any additional questions with the new protocol, please don't hesitate to reach out to us, and we'd be happy to address those. I do also want to, again, reiterate that we are aware that there are 2 other competing trials in this space. The Pacific 4 and Keynote 867 are both looking at similar patient populations and similar concepts around the addition of immunotherapy. But especially for sites who may have had one of these trials open and found it particularly challenging to accrue, we do think there are specific reasons that our trial may appeal to patients who did not want to enroll in Pacific 4 or Keynote. Our duration of immunotherapy is significantly shorter than either of those 2 trials. Patients on our trial only receive a total of 6 months of atezo versus 24 months on Pacific 4 and 12 months on Keynote 867. We also are not requiring placebo infusions, and that has been a major sticking point for a number of patients. We are proud of the fact that the timing of immunotherapy relative to SBRT is based on preclinical data from one of our translational co-investigators, suggesting this is a particularly synergistic approach. And then finally, this is the only one of the 3 trials that allows sites to gain accrual credit within the cooperative group system. So we certainly want all 3 trials to be successful. But if you have had difficulty accruing to one of the other 2 trials, or if you have colleagues who have, we'd love you to still consider opening S1914 at your site, because we have found that some sites are finding it to be a much easier trial to accrue to. So here's the current study status. As of yesterday, our accrual was at 120 of 480 patients. So we are now at the 25% mark. So really want to thank everybody who has contributed to the accrual. You can see here, we have had occasional months where we've reached or even exceeded our 8 patients per month. And actually for August, which is not on here yet, we are at 8 patients as of yesterday. So we're hoping that summer lull has kind of picked back up. But to get back on track, we really would love to start hitting 10 or 12 patients on a monthly basis. So absolutely anything that we can do to help sites accrue. I also really wanted to highlight our top accruing sites here. A huge thank you to Methodist Medical Center of Illinois, our top accruing site. They have accrued 6 patients. And then we have a 4-way tie for second place with Mount Sinai, the University of Arkansas, the University of New Mexico Cancer Center, and the University of Wisconsin Carbone Cancer Center. So a huge thank you to all of the sites that have been contributing patients to the study. And then finally, any questions? The best email address to use is the entire study team email address, the S1914 medical question at SWOG.org. That goes to all of us. We're all of the physician investigators on the study are on that email. So that is usually the way to get the very fastest response. But you can also reach us individually at our email addresses here. So now hoping to open it up to any comments or questions from the group. And in particular, we'd really be interested in hearing about any challenges that any sites have been having or anything that we can clarify or do to make things go more smoothly.
Yes, I think this amendment will help a lot of sites in that, people have asked about 8 fraction regimens since we are allowing central tumors. People have certainly asked about, multiple tumors. Many of our patients do have a single lesion that's been biopsied, but they may have a second lesion that's suspicious and or confirmed. And so, right now those patients have been ineligible until this amendment. So I do think there's some real nice benefits to this new amendment. Are there other challenges that sites have seen that's not addressed by this amendment that we should consider for future changes?
Hi, this is Michelle Brockman from the Genentech team. I wonder if I could so I know you both have done a lot of grassroots efforts to reach out to sites to ask them, the positives and the drawbacks for the trial. And I wonder, when you flip up that slide that shows the sites that have gotten into the groove of putting patients on, if maybe it would be a good idea to reach out and ask them what they find most helpful about that process, right? What's working for them that you could feed back in to the team. I don't know if that might be or if there anybody on the call today that could feed back what's working for them.
I think that's a great idea. I don't know if we have anybody on from Methodist or Mount Sinai or University of Arkansas, University of New Mexico, University of Wisconsin, any of our top accruing sites. But if anybody from those teams is on today and has any comments or suggestions.
It's notable that Mount Sinai actually had the keynote trial open for, I think a year and a half and had 0 accruals to it. And because they were having so much trouble with the placebo and the long duration of immunotherapy, they decided to open this trial. And now they're tied with our second leading accruer. So this trial, there are patients definitely in our clinics, and I do think this trial, compared with some of the others, is relatively easy to accrue to.
Hi, this is Noel Sagel down in Sarasota. Chuck, it's been a long time since we've seen each other. Hope you're doing well. I think I missed the first part. So an 8-fraction regimen is part of the amendment?
That's right.
Yes.
Oh, that's wonderful. Because we recently had a perfect patient, but I wasn't able to enroll her for that reason. And are there new dose constraints listed in the protocol?
Yes. Yes.
Oh, perfect.
Yeah. So yeah, we're hopeful that'll allow more of the ultracentral tumors to enroll.
Megan, this is Michelle again. One of the things we talked about was an FAQ, and I know that you have that, right? So I frequently asked questions. Can you just remind folks where that is and how they can get access to that?
I don't think we actually have it up on a website yet, so we can distribute that to this list. Chuck, we don't have that up on a website yet, do we?
I don't think
No.
we do.
We will distribute that to this list and see if we can find a home on an appropriate website for that. Many of the FAQs are things that I think have been addressed with this. I think by far our most common FAQ was about the assessment time points. And I believe this amendment does address that pretty nicely. If anyone reads it and disagrees, please reach out, and we are happy to do anything we can to make that more clear cut. Oh, I see we have a question from Lisa Zimmerman.
Yeah, hey, I'm an MSL with Genentech, and I have an investigator at Baptist, so I see he's on the good list, not the naughty list. And but one feedback that he got. Now this was back in the spring, which obviously recorded his feedback, but he mentioned that the protocol has the stringent cardiac function and pulmonary function criteria, and very few patients would get SBRT. And excuse, I'm not a rad onc, but will the amendment, which now changes that to 7.5 grade times 8 fractions, will that alleviate any of those concerns about those criteria around cardiac function?
So they're kind of two separate things. We have actually removed the pulmonary function criteria.
Okay.
After a group discussion, it was decided those are actually not really evidence. There's not clear evidence that that's necessary for safe delivery of SBRT. So we removed those. The cardiac function is really just for patients who have undergone recent cardiac function. So we are trying to exclude patients who may not safely be able to receive infusions, or who might have, a major cardiac comorbidity that's going to affect their life expectancy within the next 6 to 12 months. But we do actually frequently get questions from investigators, and we tried to clarify this very much, that whether the patient needs to undergo a cardiac workup. That is not the case. It's just if they have had an ejection fraction recently and it was below a certain level, then we're excluding them. We're trying to capture those serious cardiac comorbidities that would affect lifespan in the short term.
Thank you for that. Appreciate that.
Any other questions or comments? Any ways we can help you?
Oh, so it looks like somebody sent a question in the chat. How do we handle equivocal PET with respect to hilar node uptake, especially if patient declines or is not a candidate for EBUS? So, based on the protocol, we do have some guidelines for when pathologic sampling would be required around size and SUV. So, if a patient does have a suspicious node, we obviously don't want patients with N1 disease enrolling. That, is very much a different clinical picture. And we do recognize that many SBRT patients may not be candidates for EBUS or may decline. And that's why we're not requiring pathologic node staging. It's only for patients who have concerning nodes on PET. But we have not felt like we could remove that requirement. Otherwise, I think we'd end up having a lot of stage 2 and 3 patients inadvertently enrolling. Are there any other aspects of the protocol that anyone has found to be, excluding a number of your patients? Any other eligibility criteria other than the requirement for biopsy, which we're aware of? And would anyone be able to comment on whether a significant number of patients are simply declining to participate, or, do centers feel like they're not seeing that many eligible patients?
Megan, this is Paul Hesketh.
Paul.
Hi. I think we have had a couple patients decline because of the possibility that they're going to have, the protracted infusions of the IO. One would think that that would be the compelling feature of the study, but for some patients, they really, as you probably know, they want sort of the minimum amount of interaction possible to try to deal with the problem. And
Yes.
so they say, well, if you can just quickly take care of it, excuse me, with the radiation, then why do I need to go on for several months of therapy? So we have lost a couple of patients for that reason. But again, I think we just need to try as best we can to provide the scientific rationale, which is very strong. But I think there clearly will be some patients that will be lost because they just don't like the concept of having to come back, for multiple infusions, even though it's over just 6 months. That's problematic for some folks.
I agree. I've had patients turn the study down for that reason as well. But
I think there, for sure, there's not much we can do for that. They're definitely minimalist patients. So one thing I've said to patients in the past, if you actually look, there are only 8 infusion visits. One of them happens during radiation. One of them can happen at the time of radiation sim. One of them happens at 3 months. So it's really actually only like 3 extra times that they come in for an infusion. Not that, that's going to make a difference, but if they fail in the nodes, that's 6 extra weeks of radiation as opposed to 3 extra visits for immunotherapy. So hopefully, they could understand the rationale. But yeah, thank you for trying to talk with those patients for sure.
And I've also found that stressing the fact that we're having more and more data from the operable setting, that there's a benefit to immunotherapy, is also helpful. I think the rationale actually continues to get stronger as we go forward with the data coming out of other settings within lung cancer.
A great point. If it helps in an immunosuppressive treatment of surgery, it should really help with an immunostimulatory SBRT. All right.
Yeah.
Any other comments, anybody? Any study teams, whether SWOG, Energy, Genentech?
No, thanks for all you're doing. I really appreciate all your leadership on the study. And these are really great ideas. Keep doing these meetings because folks are thinking about what you've said, and that's the important seed. So thank you for doing that.
Yeah, thank you, Michelle, for all of Genentech's support. And I think we'll try and do another investigator meeting in a few months. We likely will not have another amendment at that point, but just to touch base with everybody about how accrual is going, recognize our top sites, and get feedback from anyone about how the new amendment is working out and whether it's helping.
So, Meg, I just had one other question. I think Judy was on the call as well,
Yeah.
Judy Johnson. I'm just wondering if, again, we've been able to outreach to the advocacy groups in terms of really talking about this study as an option. Judy, do you have any comments in that regard?
We have not reached out specifically on this trial, but we can explore that. And this would apply to, now, let me just make sure I understand. Are there any elements of this trial that have to do with targetable mutations, or is this, that's what I thought. So none of those groups would be interested in it because they would not be eligible. So it would be the more general population of patients. We could probably get in touch with longevity, maybe go to maybe American Lung Association to highlight it. That's my initial thought.
I think that's a great idea.
I think it's just nice if the patients come in really with that thought in their mind already, even before you've had a chance to talk to them, you know.
Yeah, and we do have patient-facing materials on this, if I recall, right? That Frank DeSanto's group put together.
We do.
So we could share those with longevity, with GoTo. I have contact in each of those organizations, and Paul, you may also, do you?
I'd have to check with Frank. I'm
Okay.
not aware. I haven't seen those specific materials.
I think Ray O is on the board of one or both of those organizations too, so he may have contacts outside the scope of the ones that I may have. That could be helpful.
I think that's a great idea.
Yeah, thank you very much.
Yeah.
Sure.
All right, well, we can probably go ahead and wrap up then, and we'll hopefully see everybody in a few months for another meeting. But in the meantime, please reach out to us, either with questions about your own patients or just any suggestions or thoughts about the study that we can possibly do to make it go more smoothly and to enhance accrual.
Thank you, everyone, for the great support.